Very good. Thank you, Mr. Hernandez. So you're supportive of the fee, of a potential fee increase for, and if you could address the TRF issue and the pro bono, the split, if there's if you have concerns with those or if you support them.
Sure. Well, principally, the CCRA has been supportive of the TRF at every step of the way, and in the prior legislative efforts to both create it and to extend it. We do expect that we would support proposal to continue the TRF, possibly extend it. As far as the fees, we have always been very open to an increase, and we're open to having that discussion. We think that it has to be looked at in the context. There are a number of other items I think that need to be looked at as we also look at it, but that increase in the maximum licensing fee under statute. And so as long as we look at all of those different issues combined together, then I think that there's definitely an opening. Can't commit to 100% to an increase that was stated earlier yet until we have a larger discussion. I mean, there's a number of items how the TRF is going to work, whether there's going to be an increase in the maximum amount, where the funding is going to go. I mean, is it going to go into enforcement where it needs to go? Is it going to go some other places? I think all of those things need to be explored. The licensees, happily pay the fee and are very comfortable with where the licensing fees go now. And so I think we just want to make sure it's going to go in the right place. And certainly we understand that the statutory maximum has been in place, I believe, since 1950, 1951. So we certainly understand that. And it's our membership, especially the official reporters, completely understand because the fee for their transcripts, for their court transcripts, has been capped in statute since 1990. So we clearly understand that sometimes some of those numbers are outdated. So I think we have to look at the big picture and definitely open to the conversation.
Very good. Thank you, Mr. Hernandez.
Thank you.
Did you have a response?
I just had a quick clarification.
Very good. Thank you.
It's the cap that's being increased to 250. It's not contemplated that the fee would immediately go from 125 to 250. So I don't know if I made that clear.
That was the cap that you were looking for.
It's just the cap, so we don't have to come back every year and say.
It took 60 or 70 years to get to the cap you have today, so you're in no hurry to get there.
Exactly.
Looks like very good. Thank you. Other members of the public? See no one. Thank you very much for your testimony, being here today, and looking forward to seeing you in 4 or 5 more years, which would be great. So,
thank you for having us.
Thank you. I would like to invite the representatives from the Physician Assistant Board, Robert Sachs, the Board President, Jed Grant, Board Vice President, Glenn Mitchell, Executive Officer, to provide an overview of the board and discuss issues raised there. Thank you. That's a good bill.
His bill, yeah, I did one last year that was on this. It was on a similar issue of where they have to disclose these big companies if they already have other clients. Because one of the other things they were doing was you didn't know if you use this one of their firm if they also were doing your opponent.
Oh, jeez.
So that was their sponsored bill.
Yeah, that's amazing. Okay. Welcome.
Good afternoon. Thank you for having us here today. Senator Hill, Assembly Member Bonilla, and the rest of the members of the committee. We are here today before you to discuss the Physician Assistant Board's functions, its performance, and potential recommendations for improvements. My name is Robert Sachs. I am the board president. I am a physician assistant and have been licensed since 1984. I've been a member of the board since 1993. Sitting to my left is Jed Grant, who is also a physician assistant and has been licensed since 2000. To my right is the board executive officer, Glenn Mitchell. The Physician Assistant Board was created in 1975 to license physician assistants in order to address a growing shortage of geographical maldistribution of healthcare services in California. As a consumer protection agency, the board's highest priority is public protection. The board carries out this mandate through its licensing and enforcement functions. Due to the implementation of patient protection and the Affordable Care Act in California, the board believes that physician assistants are an important part of the solution to help address the healthcare shortages now taking place as more consumers have access to healthcare in California. Currently, there are approximately 10,555 California licensed physician assistants. Since our last sunset review, there have been many changes at the board. Some of the changes include the Physician Assistant Committee became the Physician Assistant Board. Scope of practice changes to the physician assistant practice to allow for a more efficient utilization of PAs while enhancing consumer protection. For example, we are now able to supervise medical assistants. Implementation of new continuing medical education requirements, the 800 series professional reporting requirements. Also, new online services such as initial application and license renewal. The next item will be enforcement measures targets. We have been asked to speak about the board's enforcement measure targets. As pointed out in our background paper, the board generally is meeting its performance measure targets. However, there is always room for improvement, and the board is committed to examining ways to ensure enforcement targets are met. DCA assistance. We have been asked to discuss if we are receiving sufficient assistance from the Department of Consumer Affairs. Being a small board with a very limited staff, we rely heavily on the expertise of the DCA units that handle the board's administration functions, such as personnel, fiscal, budget, legal, licensing and enforcement tracking systems, and also cashiering functions. The Department of Consumer Affairs also handles physician assistant consumer complaint investigations. We also rely upon the Medical Board of California, with whom we have agreements for consumer complaint processing and its IT services. We believe that the DCA provides these services in a satisfactory manner to assist the board in carrying out its administrative functions in a timely manner. Board staff feels that administrative and enforcement functions performed by DCA staff are meeting the needs of the board to ensure administrative functions are performed in an efficient manner. This concludes my overview of the board. Do you have any questions so far? Okay, I will go into issue number 1 then, which is fund condition. We have been asked to comment on whether the board's current reserve will be sufficient to accommodate the number of licensees and whether the board believes a fee increase will be necessary. As you are aware, board staff, our budget is reviewed by the Department of Consumer Affairs budget analyst. The DCA budget analyst works closely with our staff to address any issues and take corrective action to ensure that the budget remains fiscally sound. Upon review by board staff and DCA budget analyst, we believe that a fee increase will not be necessary at this time. It has been projected that the board's fund balance will be sufficient for the next several years to address its operational needs. The fiscal year 2016/17 funds months in reserve are projected to be about 23 months. This is due to the repayment of the board's outstanding loan to the general fund of $1.5 million. Budget language does not allow our board's reserve to exceed 24 months. If the board's reserve exceeds 24 months, fees must be lowered to reduce this number. Therefore, a fee increase would not be appropriate at this time. The board's fiscal issues have risen out of increased enforcement costs, specifically Attorney General's cost. To address this shortfall, the board has sought and received budget augmentations to cover these costs, SB 467 language. To address potential increase in licensing workload, board staff will be conducting a workload study to determine if additional personnel will be required. At this time, I will ask the Vice President, Jed Grant, to speak on issue number 3.
So the next issue we want to address is enforcement. And the board is requesting that the Physician Assistant Practice Act be amended to allow it to take disciplinary action against a licensee or deny an application for a license based on the denial of licensure, revocation, suspension, restriction, surrender, or other action against a healthcare professional by another California healthcare professional licensing board. The Board of Registered Nursing has a similar law, which is Business and Professions Code, Section 2761, Sub A4. Business and Professions Code, Section 141, gives the board the ability to take disciplinary action against a licensee who has been disciplined by an out-of-state licensing or governmental agency. As the board currently has dual licensed physician assistants, this change would allow us to pursue disciplinary action in a more cost-efficient and timely manner. This would avoid the board needing to reprove a case, which would involve investigative and attorney general time and funds. Often the need to reprove a case can present difficulties, such as witnesses that are no longer interested in discussing the matter or are no longer available to interview. It should be pointed out that the licensee would have the opportunity for due process in any proposed disciplinary matter. We believe that investigative and attorney general time is valuable, and these resources could be better spent pursuing other disciplinary matters than reproving a case that has already been proven in another California board. Additionally, this inconsistency is confusing to consumers who, for example, would verify another healthcare license which would indicate disciplinary action. They would then view the physician assistant license that would indicate a clear license. The consumer could interpret this inconsistency as a lack of disciplinary consequences to violations of the law. As a consumer protection agency, it is imperative that the board be able to take disciplinary action as soon as possible. There have been cases, for example, when a licensee surrenders their nursing license and is able to continue practicing as a physician assistant. The board does not have the ability to quickly mirror the discipline taken by the Board of Registered Nursing. Again, the public finds this confusing and inconsistent in what they may perceive as a board not protecting the public. We believe that this amendment to the Physician Assistant Practice Act is a valuable tool in assisting the board in its role in consumer protection. As a public protection agency, it is imperative that the board possesses the necessary tools to quickly discipline licensees who have violated laws and regulations, including those who are dual licensed in California. We respectfully ask that the committees consider our request to amend the Physician Assistant Practice Act to include this important provision. The next item is number 4, Breeze.
Thank you. I have been asked to update the committees about the current status of the board's implementation of Breeze, discuss the current and anticipated challenges, and recommend potential solutions that the Department of Consumer Affairs should utilize to assist the board in the use of Breeze. As has been stated in the board's sunset report, implementation of Breeze by the board has been an ongoing challenge. Board staff feel that while some issues concerning the implementation of the system continue, they are sufficiently supported by DCA and Breeze staff to continue full implementation and utilization of the system. I'd like to tell you a couple highlights of our implementation, what we've done so far. The major one is online license renewals. We started that feature in May of 2015, and it functions properly. It's very popular with our licensees and their employers. It's also popular with staff that it has cut down on our time processing. We find that we're getting a lot less paper renewals and more online renewals. Part of the issue is we have to update our renewal notice to reflect the availability of the online renewal process, and that does take time with the Breeze system to update the forms. But staff has been proactively telling people that call in about renewals that they have the ability to renew online. So that feature has been very helpful to us. The next feature is our initial online application. We've been enhancing that feature. We just recently revised our application, and we are going to roll that out probably sometime in the summer. And currently, an applicant applying online has to also submit a paper application in addition to the online. So once this rollout occurs, they will no longer need to submit a paper application. So that will save a lot of time with the applicant, will save time with the staff, and it will get the licenses out much quicker. We'll have less paper moving around. Another issue is the CME audit. We were tasked with having an audit system in place by the next sunset this time, and unfortunately the BREEZE system was not able to accommodate that. So we have been working with another board, and now we're working with BREEZE, and it looks like they were going to be able to put something together for us, and that should roll out probably sometime in the summer as well. So we'll have that feature available to us. The other issue is BREEZE licensing and enforcement reports. The reliability and accuracy of the BREEZE licensing and enforcement reports has been an issue with the board as it relies heavily on reports to track licensing and enforcement matters. Without accurate reports, the board is not able to track licensing and enforcement data to determine if performance targets are being met. It appears that the licensing and enforcement reports are being generated by BREEZE are becoming more accurate and more reliable and more usable to the staff. We continue to work with the BREEZE team to ensure that the reports become more accurate and eventually where we can fully rely on them. Potential challenges to the board include assistance to understand and implement BREEZE. This is especially critical for a small board like the PAB. Staff do not have the technical background or a great deal of time to devote exclusively to BREEZE. These issues were discussed in our sunset report. We can now report that the BREEZE team have been very helpful with implementation of changes to our system. They now spend time explaining the system, setting up meetings with us to review requests, and ensuring that we understand the process and procedure. They are very knowledgeable, helpful, and available to answer our questions. Because of the enhanced communication, staff is able to gain confidence in the system, which allows us to fully utilize it. This is a major positive outcome for the board. Another issue is staff has requested post-training. Once they've started the system, now they want to go back and learn some additional features. It appears that the Department of Consumer Affairs is now going to be scheduling additional training for people already using the system. I also would like to again say that we do receive a lot of support from the Medical Board of California, their IT office. A lot of our systems are sort of aligned, so they're able to help us understand the system. But in conclusion, I feel that the department now is finally listening to the smaller boards that don't have the expertise to understand the system, and now we're getting that help. So that concludes my part. Thank you. Thank you.
Okay, we have one more item, issue number 8, which was the associate degree pathway. When the physician assistants originally started becoming licensed, the majority of us were returning Vietnam veterans back in the mid-1970s, 1980s. The majority of those programs were 2-year associate degree programs with heavy emphasis on hands-on training. I would not be sitting here today if it was not for that capability. That all started to change in 2000 when the national accrediting body decided that they were going to move towards a master's degree level for all PAs. Sitting next to me, Mr. Grant was a program director of a 2-year program. He is also currently an educator and a member of the California National Guard, and he has been very forthwith in working on this issue for a number of years with us.
So I think, and if I could add on to that, when you're looking at the history of the PA profession, and with where it came from, like Mr. Sachs mentioned, initially in the profession, there were PAs in practice who had certificates, associate's degrees, baccalaureate degrees, and then master's degrees. And so when this change began to happen in the profession, all of the stakeholders got together and said, where should we be on this issue? Because it's confusing to have people with all sorts of different degrees doing the same thing. And that is because the profession was traditionally competency-based. So the degree was less important than what could you do. So there are there's a professional organization nationally, a certifying organization, and an accrediting organization. And in the early 2000s, they met and came up with this rule change. The end result is that the entry-level degree for PAs is going to be a master's degree. That was problematic in California because we had 3 associate degree programs. And so in the last few years, 2 of those programs have closed. The accrediting body, which is the ARCPA, was very clear that they did not have an agenda to close the associate degree programs, and they made a pathway for those programs to affiliate with a master's degree granting institution if they met certain requirements. While the closure of the associate degree programs in California was not caused by the degree change issue, it did play a role. There is one remaining associate degree program in California who has plans to transition to the master's degree by 2020, which is the deadline. The master's degree reflects the academic rigor required in PA education, and as I mentioned, was widely discussed by these national organizations before this implementation, including extensive study, analysis, and discussion with input from stakeholders. The profession has essentially decided that this is going to be the entry-level degree, so for California to try and change that would be difficult and at odds with the entire profession. As mentioned in the Education and Workforce Subcommittee report on alternative accreditation, it may lead to increased expense and complexity for licensing in California to try and have an alternative accreditation. It may not actually increase the workforce in California, and it may, in the long term, decrease access to care for Californians. We feel that further study of the degree issue at this point would be duplicitous and counterproductive, as the profession has essentially decided on a national level that this is going to be the entry-level degree. The accrediting body has a similar mission to the PA board and fulfills a vital role. They generally do an excellent job of ensuring the educational quality for PAs nationally by certifying PA programs. The PA board accepts the Accreditation Review Commission on Physician Assistants, or the ARCPA, accreditation for PA programs in California. The problem with the ARCPA, if there is one, is less in content and more in delivery. We've had attempted communications with them several times over the last few years, and they have been not encouraging. However, more recent communications have been productive in where we're trying to work with them on workforce issues with the closure of the associate degree programs. The implementation of a master's degree as the entry-level degree certainly has changed the face of the profession. But that issue is really beyond the scope of the board. There is no shortage of PA applicants to PA programs who may have up to 20 qualified applicants for each available seat in the program. With 7 programs pending accreditation in the next few years in California, in addition to the already accredited programs, the number of PAs being educated in California is rapidly surpassing the number produced by the closure of these 2 programs. So we're still on a net positive, even with the closure of those 2 programs. The main limitation for expansion of PA programs in California and also nationally is the availability of clinical training sites and preceptors. 50% of PA training occurs in a clinical environment with clinicians who are not paid or have minimal non-monetary incentives to train PA students. There has been an expansion of PA programs from outside California who pay preceptors within our state to send students from outside California to train, which contributes to the already high cost of PA education and leads to a myriad of problems in PA training. The state of Georgia successfully implemented a modest tax incentive for clinical preceptors, which has been successful in overcoming some of these barriers and increased the available number of training sites. The Education and Workforce Subcommittee of the PA Board is looking into how California may pursue similar legislation that would encourage PA training and retention in medically underserved areas of California. While this issue does affect veterans for the reasons that Mr. Sachs mentioned, the effect is the same across the nation and really is even true for applicants to the military PA program who is accredited by this same accrediting body and has the same requirements to meet. There are several options available for veterans who want to attend PA school, and there are pathways for them to get there, including funding, but addressing those issues is really beyond the scope of the board, which primary mission is consumer protection and workforce issues for California, which, as I mentioned, are currently being met. So that is the end of our comments. We're certainly
Very good. Thank you very much. The questions? Yes. Assemblymember Baker.
Thank you. Just wanted to follow up briefly on the statement that was made in discussion of the BREEZE program and how it's going. And I appreciate your update. You mentioned that the enforcement and licensing reports are appearing to be more accurate and reliable.
Yes.
Can you talk a little bit more about how you know? How are you checking?
We are actually working with the medical board, and they're having the same issues, but because of our smaller population size of, say, licensing and enforcement matters, they're able to actually go back and manually look at cases that we have. We have in the office, we do keep manual records of a lot of our processes so that we can track it. But it's through going back and testing and looking at what, and they're probably not exactly 100% accurate, but it gives us a better idea that, well, we have 30 of these and this is off maybe 40, so, you know, we're getting in the right direction. I think part of the problem with the BREEZE system was that every board had a different definition of what an open case was or what initial license meant. And that created issues when you're putting together reports. What exactly do you mean by the end of that case? What is the end of that? And I think that's where the department is struggling with trying to come up with common language so that we all are speaking the same language when we build our reports, because the reports might not be inaccurate, but they don't reflect our particular you know, timelines or our particular definitions of what these type of cases are.
And do you, based on the experience you're having now, do you have a, well, first I'll say there's more wrong with BREEZE than what you identified, but subject of another day. Do you have a sense of when would be a reasonable time frame based on what you're experiencing where you're going to have much more fully accurate and reliable reports?
I don't have an answer for you because I think maybe the department can give you a better outcome of that. But I can tell you that we look at, say, for example, our licensing reports, and we're now able to use those for our board meetings, whereas before we were pretty much manually adding how many people we had. So I think it's a gradual process. My feeling is I don't want to release a report just because I can say I release a report if the information is not correct, because then I have to defend that. And if it's not accurate, there's no point in having the report. And I think what the boards have been doing are rejecting those reports until they're essentially usable.
Well, pleased to hear that they are getting, from your own experience, getting more accurate and reliable, and hopefully they will continue to be.
And they're putting they're devoting more staff to do that. So we feel, as I said, we're saying no until we feel like that report, we can actually defend it and use it.
Thank you.
We want to have reports, but, you know, we want them accurate.
Right.
A question on the board makeup. You have an ex officio physician and surgeon. How does that working in the makeup of the board, one, and in the operation of the board? Is there a comfort level all the way around with that?
Well, we've only had one meeting since it became effective. It became effective in January this year. Wow. And at the meeting, I had to inform Dr. Bishop that he was no longer a voting member. He could participate in the discussions, and he could not participate in any closed session. So we're going to give it a try because it just started. At the sunset hearings in 2012, we had requested that we maintain the physician member on our board because of the close affiliation that we have with the medical board and the fact that we cannot promulgate any regulations that affect physician supervision. So the legislature thought otherwise. They wanted us to be an independent board and put this into place. So in answer to your question, it has worked so far. I have concerns about asking somebody to fly up from San Diego and sit in a board meeting all day and not be able to vote.
I see the problem. Very good, thank you. Other questions? Very good. Thank you very much. Oh, any members of the public would like to comment on the physician assistant board? Thank you for coming forward. Anyone else would like to come forward? Seeing no one, thank you.